There are no older people here except Prabhakar. Good morning to all older people and younger people. Today you are going to see a very rare case. Probably you will not see many cases like this in your lifetime. Yesterday I was speaking to one of my FRCP friend Ravindran, who was the chief of the Rheumatology Association in India and also Europe. He told me he himself not seen many cases. This is my photograph when I went to meet my professors in London. They were in Brighton, they are retired now, but they were my teachers when I was a student. You can see the column, the best teacher is the one who brings best out of the students. I am fortunate to have two best teachers. To right of me is Professor Richard Vincent. He is so popular in cardiology and also is inventor of the pacemaker. He is a professor of cardiology in Medical College and a professor of physics in University of Brighton. Physics, professor of physics. Left is Sir Douglas Chamberlain. He is teacher to my teacher and also is teacher to me. He is retired at that time, but he used to come for teaching the students. So I was so lucky that I have the two best teachers and my life was easy at that time. So today I am going to talk to you about BEHCET disease, which is a very rare disease. Pronunciation is something hard. BEHCET. Ha should be little lesser, not BEHCET. BEHCET. And some people they pronounce a BEHCET, but usually BEHCET is the correct spelling. And first I will give you some questions to stimulate your sleeping brain. And I know you know all the answers, but still you just note them the answers in your mind. And at the end of it you can mark yourself and you can give award yourself. The first question, BEHCET disease, a congenital disease, A. Congenital disease, B. Autoimmune disease of uncertain etiology, C. A transmissible disease, D. Streptococcal disease. So you have to tick one: congenital disease, autoimmune disease, transmissible disease, and streptococcal disease. Am I fast? It's okay. It's okay. Second question: BEHCET disease cause recurrent urogenital ulcers. B. That is A. B. Eye involvement with both posterior and anterior uveitis. C. It is a relapsing disease. D. May cause pulmonary arterial aneurysms. E. All the above. Third question: BEHCET disease a vascular is a question. Question A. Third question A. A vasculitis involving large, medium, small arteries and veins. So a vasculitis involving large, medium, small arteries and veins. B. Vasculitis involving small arteries. C. Vasculitis involving the venous system only. D. It is a dermatological condition affects the superficial layers of the skin. 4. BEHCET disease could be diagnosed by A. Blood test and specific markers. B. Biopsy of the ulcer. C. Pathologic skin test. D. Clinical diagnosis only. There is no specific test exists. Question number 5. Treatment of BEHCET disease involves A. Corticosteroids, B. Immunosuppressive drugs like ethioprine, C. Immunoregulators like sulfazine, colchicine, D. Monoclonal antibodies like infliximab, E. PDE inhibitors like everolimus, and F. All the above. Sixth question: BEHCET disease. One of the statement is false. A. Is a common along the Silk Route of countries. B. It was named after Turkish dermatologist who described it in 1937. C. It is a fatal disease. D. It is associated with HLA-B51. So now you can mark your answers and we will discuss at end of the talk. It's very difficult to talk like this, Sunny. I will present my case. Mr. Satvik, 17-year-old male patient, was brought to our hospital on 30th June 2023. He has been suffering from high-grade fever with chills. He has got oral ulcers He has got ulcers on glands and on the scrotum for the last 1 month. He also had a pain in the left ankle. For the last 3 days, he has redness of both eyes, right more than the left. He was hospitalized in Rajam for 10 days, Rajam Hospital, after many outpatient consultations with various papers. He was given multiple broad-spectrum antibiotics and antifungals intravenously. His symptoms did not abate, hence he was brought to our hospital. On examination, when he came to our hospital, he is febrile. He had got a throat and scrotal pain. He has a large ulcer on soft palate and multiple aphthous ulcers in the throat and lips. He has a large ulcer on the medial aspect of the scrotum on right side. He has also multiple ulcers on the glands. He has congestion of both eyes, right more than the left. He has a history of skin rash, the maculopapular rash, in the beginning of the fever, as noted by his previous doctors. So he has got a throat ulcer, ulcers in the mouth, he has got a scrotal ulcer, he has got ulcers on the glands penis, and he has got a congestion of the eyes. There is a big ulcer here. You can see in the closer view, there is a big ulcer. The colors are not coming well. He has got aphthous ulcers on the lips and also on the throat. This is the scrotum. He has got a very big ulcer here. The ulcer here. Same photograph. It is with the light and this is without a light. This is all ulcer and ulcer margins. There is aphthous ulcers here. There is a big ulcer on the scrotum. And glands penis, you see, multiple aphthous ulcers. I don't know, we should call it ulcers, I think, we should not call aphthous. And his eye is congested. You can see the congestion of the eye. So these are the blood reports done outside actually. Total WBC is increased, 17,000. ESR is increased 18 millimeters. CRP is very high, 115, normally 6. Hemoglobin is little less. Renal functions, liver functions, electrolytes are normal. Peripheral smear was normal. Throat swab culture was no growth. Blood cultures no growth. Ultrasound abdomen normal. CT scan chest normal. 2D echo ECG were normal.
What is the differential count?
Pardon?
Differential count.
Polymarks?
DC,
I think it is wrong. It is 92. It must be 92, no? 6118.
Yeah, 92.
92.
90.
I didn't check actually. Typing. HBsAg, HIV or negative. Dengue serology negative. Scrub typhus negative. Vidal negative. ANA profile negative. VDRL negative. Treponema pallidum and hemoglobin test negative. This is for the syphilis. ASO titer was negative. Rheumatoid factor was negative. And pathogen test was negative. This pathogen test usually done for the BEHCET disease, not very specific, but one of these tests, it also positive in some other diseases like leukemias and all. The pathogen test is you just prick with a needle, and after 48 hours, the puncture should become a sterile papule, or at least erythematous papule, within 48 hours. That is positive pathogen test. We tried on this boy, but it came negative. So, in consultation with our dermatologist, Dr. Saujanya, a clinical diagnosis of BEHCET disease was made, and we started on Canacot oral ointment and Defcot orally steroid 24 milligrams a day and colchicine every 6 hours. See, whenever you make a diagnosis on clinical grounds alone and where there is no specific test and this is going to be a prolonged illness, better we consult a colleague. That's what I did here. So no need, actually I made a diagnosis of BEHCET, but you should not do mistakes. Maybe I am wrong. So you should take consultation from another colleague to be confident. So review of the patient after starting steroids, 5 days after 5 days review revealed very good response. Oral and scrotal ulcers are already healing within 5 days. Though glands penis ulcer pain is reduced, it was still active. This is the ulcer before treatment. This is the throat after treatment. It's almost healing. This is scrotal ulcer before treatment. This is scrotal ulcer after treatment. Usually, BEHCET lesions they heal by scarring, especially scrotal lesions. They scar while they heal. So now I will tell you some of the theoretical points about BEHCET disease. BEHCET disease is a rare systemic vasculitic disorder characterized by a triad of oral aphthous ulcers, genital ulcers, and uveitis. The triad is oral ulcers. There must be another word: recurrent oral aphthous ulcers, genital ulcers, and uveitis. It can also present as skin mucosal lesions, arthritis, arterial and venous vessel disease, gastrointestinal and neurological manifestations. He is Mr. BEHCET, Dr. BEHCET, a dermatologist. BEHCET disease was first described by Hippocrates in 5th century BC. It was mentioned by Hippocrates, but the disease was named after Halas BEHCET, a Turkish dermatologist who diagnosed the case in 1924 and published a detailed report in 1937. This is his first report. It looks like a Latin. It was published in 1937. The disease is very common along the Silk Road. The Silk Road starts from Japan, through China, through Middle East, Mediterranean, hence in Constantinople, or we call Istanbul now, or Egypt. This is how the silk is transported, but also it has contact with Delhi. So along these roads, the BEHCET disease is very common. The patients are most commonly from Middle East, Mediterranean, and Far East. The most prevalent in Turkey, 1 in 250 adults have BEHCET disease. It's very high. Adults, not total population, adults. Less than 1 lakh cases per year in India. A male and female are equally affected, but male have a severe disease. It is rare before late teens and after 50s. That is very common in 20 to 40 years. How do you make diagnosis of BEHCET syndrome? BEHCET syndrome is diagnosed clinically. There is no specific laboratory, radiological, or histological feature that can help in the diagnosis of a patient with suggestive symptoms. Diagnosis is based on combination of clinical features and exclusion of other diseases, similar diseases. You should exclude before saying a BEHCET disease. So usual lab findings in BEHCET disease are increased CRP, increased ESR, increased WBC count, and increased inflammatory markers cholecalcitonin, ferritin, fibrinogen, TNF, IL-1, IL-6. There are recent reports that serum calpoprotectin, that what we do for inflammatory bowel disease in the stool, that serum calpoprotectin is elevated. There is one paper published, 45 people among the 47, they have a serum calpoprotein elevated. But it is not and confirmed that is very specific or what is the role in prognosis and all at a theoretical level. It is usually associated.
Is it common only in Crohn's disease or ulcerative colitis also?
Which one?
In
Calpoprotectin, all inflammatory bowel disease. Most common in ulcerative colitis and Crohn's disease.
Okay.
It's a marker of inflammatory bowel disease. Then you have to differentiate. This is elevated in this BEHCET disease, the serum, not in the stool. It is in the serum calpoprotectin. HLA-B57 is positive in 60% of the people. But this cannot be taken as a big marker because 20% of the population himself is HLA-B51 positive. So there is a confusion about the diagnosis of the BEHCET disease, though there is an international study group made a criteria for diagnosis of BEHCET disease. Oral ulcers, it should be 3 times in 12 months period. This boy have oral ulcer, recurrent ulcer for last 6-7 years. Plus 2 of the 4 below, that is recurrent genital ulcers, skin lesions, eye lesions, and pathology test. If 2 of them is positive, this is BEHCET disease with oral ulcers. Skin lesions not only they also have erythema nodosum, pseudofolliculitis, papulopustular lesions, acneiform nodules. So eye lesions include anterior posterior uveitis, vitreous and retinal vasculitis. Pathargy test is 50% positive, but this is mainly positive in the people with the Mediterranean Turkey people, not in other communities. You don't know the reason. Pathogenesis and etiology are unknown. There is no specific theory that this comes like this. Possible genetic predisposition is there because you see along the Silk Route, there will be some, that's how it was spread along the skin route. And inflammatory immunological mechanisms may play a role, but unlike other immunological diseases, there are no acute antibodies, no Raynaud's phenomena, no thrombocytopenia, no hemolytic anemia, and no Sjogren syndrome. These are against the immunological process alone. There is a tendency to abate with time. It may relapse and may go off in some people. Different clusters of disease. In Japanese, GAT involvement is very common. In Turkey people, oral genital ulcers and UIT is very common. So it varies, the disease varies. Unlike other immunological disease, they are always same in anywhere in the world. So there are doubts whether it is immunological, non-immunological, genetic or something else. So this is a disease, I told you earlier, involves all the arteries, large vessels, medium vessels, small vessels and veins. The rest of the vasculitic lesions, either they involve large, medium or small vessels. The large vessel, giant cell arteritis, Takayasu disease, medium sized vasculitis like polyarteritis nodosa, Kawasaki disease, small arteries vasculitis, microscopic cholangitis, vaginal granuloma, Church-Strauss disease. Small vessel disease with immune complexes, SLE, henoxational purpura and Guch-Passer syndrome. So these are all involves a specific part of the arterial system or venous system, but BEHCET says involves the larger arteries, small arteries, medium arteries, small arteries and veins also. The clinical features, skin and mucous membranes are commonly affected. Oral ulcers, 90% people have oral ulcers, 80% have genital ulcers. Acne and papillar is also common. Erythema nodosum is more common in females. They can have also pyoderma gangrenosum. 25% have vascular disease, superficial thrombophlebitis, BVT, pulmonary artery aneurysm, Budd-Chiari and inferior vena cava syndrome. 50% of the people will have eye involvement. They can have a bilateral uveitis and hypopyon, and people having posterior uveitis, vitreous opacities and macular edema more likely to lose their vision. The posterior involvement more likely to lose their vision. 50% have arthritis. Usually arthritis is monoarthritis or oligoarthritis, is non-erosive and non-restrictive. 5% people have a neurological manifestation. Most of them affect the parenchyma of the brainstem and spinal cord. They usually present with headache, cranial palsy, dysarthria, ataxia or hemiparesis. 1/3 may have a cerebral venous thrombosis. Gastrointestinal manifestations are variable, as I told you. In Japanese it is very common, and Mediterranean countries this is less common. 50% involvement in Far East and rare in Middle East may present as a solitary ulcer which may perforate, and it early stages it is indistinguishable from Crohn's disease. The cardiac involvement is rare but described pericarditis, myocarditis, endocarditis and coronary vasculitis and coronary aneurysm. Coronary artery vasculitis, very dangerous. They may present to Dr. Mahesh with acute coronary syndromes, and coronary artery aneurysms may rupture and sudden cardiac death can occur. Dr. Nehru is safe. Renal diseases are very rare. They are rarely reported amyloidosis and various type of glomerulonephritis. So what are the differential diagnoses? Anything causes oral ulcers, scrotal ulcers, or genital ulcers and oral ulcers combination, you have to differentiate from BEHCET disease. Drug reaction is very common in our area, but usually it is evident from the history and the acute presentation. And venereal disease like syphilis, they can have oral ulcers and genital ulcers, and chancroid, they can also have oral ulcers and genital ulcers. Inflammatory bowel diseases, Crohn's disease and all, they may have oral ulcers. They can have arthritis also. Eye involvement also can be there. So you must be careful in differentiating. A seronegative arthritis, HLA-B27 related ankylosing spondylitis, Reiter's disease, They have a oral ulcer, they have a uveitis, but their uveitis is usually unilateral. They have a back pain, arthritis, but you can differentiate by markers and all. And SLE is a common mimicker. He can have oral ulcer, arthritis, and genital ulcer is rare, but he can have uveitis. Among them, orogenital herpes. They can present its oral ulcers and genital ulcers. Recently, I have seen a boy having plenty of oral ulcers. Mouth is all gone with genital ulcers. You know the reason. Treatment depends on the severity of disease. All diseases are not very severe. Depends on the severity of disease. Most of the new manifestations occur first 5 years of the life. So what are the manifestations? Uveitis all happen within 5 years. 5 years after that, there will be quiescent period. The symptoms will not aggravate, and remissions may occur. So you should be careful in treating the conditions. The mucocutaneous manifestations like oral genital ulcers can be treated with the topical steroids, topical sucralfate, or topical anesthetic agents. Recurrent ulcers are recurrent. You can try with colchicine, epidemiolast, and still not responding. You can go for oral prednisolone. If ever treatment fails, you should go for azathioprine or interferon alpha. This is for the oral mucocutaneous ulcers. Arthritis usually respond to non-steroidal anti-inflammatory drugs and colchicine, prednisolone. If you fail, then you can go for higher drugs like azathioprine, TNF alpha inhibitors. Eye is a dangerous place because if the posterior uveitis occurs, they may lose vision. So this is the one condition where you need large dose methylprednisolone for 3 days pulse therapy. Usually, they may respond to anterior chamber lesions, may respond to steroids, local steroids. If not, azathioprine, TNF alpha inhibitors can be used. GAT usually respond to sulfasalazine, steroids, and azathioprine. The vascular diseases are very difficult to treat because giving anticoagulation is a difficult situation in this condition. They may require high dose steroids, cyclophosphamide. Anticoagulation are indicated only if cerebral venous thrombosis. Peripheral venous thrombosis, you have to treat with high dose steroids and cyclophosphamide. Then if you want to give a steroids, anticoagulation, you should exclude a pulmonary artery aneurysm before doing anticoagulation. This because they may die with rupture of pulmonary artery. Pulmonary artery aneurysms are very common, those who have a peripheral vascular disease. So if you want to give a anticoagulation, you have to exclude pulmonary artery aneurysm. Thank you.